breast cancer is always caused by a genetic abnormality, so there's some mistake in the genetic material. Whether that's something that happens by accident or it's something that happens because you have a genetic disease that makes you prone to that, it doesn't matter. It's always some mistake in our DNA. And only about 5 to 10% of cancers are due to something that we inherit from our parents. Most of them are due to the wear and tear on our DNA or mistakes. I think about it like a game of telephone. It's, by the time you have one little mistake in the DNA, and then it starts replicating, and those mistakes get bigger and bigger. So the statistics on the number of women in the US, I usually say 1 in 8. I saw some newer literature that says 1 in 7. The 13% is about 1 in 8 women will develop an invasive breast cancer over the course of their lifetime. If you look at the CDC, and the last year that they have reported statistics is from 2021, and we saw a drop because of the pandemic in reporting and people being diagnosed because of the barriers to getting health care during the pandemic. But almost 300,000 new breast cancers were reported. In 2022, about 42,000 women died from breast cancer. But we know that women have much higher rates of getting breast cancer than they do from dying of breast cancer. So we have right now more women living with breast cancer than any other time in our history. So from about 2017 to 2021, 2 out of 3 females were diagnosed at a localized stage. That means it was contained to the breast. About 1 in 4 women were found at a regional stage. That means it had moved from the breast into the lymph nodes on the same side in the axilla, which is kind of whenever you get a breast exam, we're always feeling up under it in here. That is because the lymph nodes sit underneath the pectoralis minor muscle. So the one that you can feel is the major, the minor's underneath it, and those lymph nodes are beside, behind, and then towards the middle. So the lymph nodes themselves are not very superficial, meaning close to the skin. Overall, 91% of female breast cancer patients had not died within 5 years. Survival rates, however, vary by what stage you are at diagnosis. So the earlier we catch it, the better the 5-year long-term survival is. So screening, so this is my big plug for most of you in the room. I think everyone's educated on screening, but screening mammograms, we know, save people's lives. For women who are average risk, a screening mammogram is the best way to find breast cancer early. And there are differing opinions on how often and when you should get them. The recommendation is you can get a baseline at 35, then every year starting at the age of 40. And my stopping point is based on functional status. So if you're 95 and still very active and you would do something about it, should we find it, then I think you should continue to get mammograms. If you're wheelchair bound and have a multitude of other medical problems and we would be able to treat you, then I tell patients, if you're not going to do something about it, there's no reason to get screening mammography, because then we're left with, what do we do since we can't do any of the standard of care things? And is it going to make your life better, or are we going to change your life for the worse? So sometimes it's quality over quantity. So death rates, we know, especially in the US, in women under 50 since 2007 have continued to drop. Overall, the death rate from breast cancer decreased 1% between 2013 and 2018. And we think that's due to the treatment advances, earlier detection, we have better screening. So we used to have the 2D mammograms and film, now we have 3D mammography, which is like taking little slices, kind of like a deck of cards, and we can look at overlapping tissue and try to discern, is that overlapping tissue or is that something we need to be suspicious of? For women in the US, breast cancer death rates are higher than those for any other cancer besides lung cancer. Breast cancer is the most common cancer diagnosed in women. As of January 2022, there were more than 3.8 million with a history of breast cancer. So like I said, there are a lot of women living with breast cancer, a lot of breast cancer survivors. This includes women currently being treated and women who have finished treatment. And then, like I said, it's the most commonly diagnosed cancer among American women. Breast cancer became the most common cancer globally as of 2021, accounting for about 12% of all annual cancer cases worldwide by the World Health Organization. In women under 45, breast cancer is more common in Black women than white women, and we know that in Black women, it tends to be more aggressive and be diagnosed at a later stage. And some of that are socioeconomic barriers, some of that is genetics. Overall, Black women are more likely to die from breast cancer than white women. Asian, Hispanic, and Native American women, the risk of developing and dying from breast cancer is lower than it is for Black women. Ashkenazi Jewish women, so Eastern European Jewish descent, have a higher risk of breast cancer because they have a higher risk of BRCA mutation. So BRCA is a gene that we all have. And in the Ashkenazi Jewish population, we know that the rates of seeing BRCA mutations in men and women are higher. We know that the incidence of breast cancer started decreasing in and around 2000. It dropped by 7% from 2002 to 2013. And one of the theories is that we realized that putting women on hormonal replacement therapy, so estrogen or estrogen and progesterone in combination, was increasing the incidence. And so what we found is that it doesn't necessarily mean everybody on hormone replacement therapy will get breast cancer, but we know that at a certain point our estrogen levels drop when we go through menopause, and a lot of cancers are estrogen and progesterone positive, and by taking these drugs extraneously, it meant that it's sort of like somebody had a loaded gun and just pulled the trigger. So it wasn't everybody getting it, but we did see a significant drop when we started realizing that hormone replacement therapy was maybe not the best way to treat perimenopause and postmenopausal symptoms. A woman's risk nearly doubles if she has a first-degree relative, so mother, sister, daughter, who's been diagnosed with breast cancer. Less than 15% of women who get breast cancer, though, have a family member diagnosed with it. So you, a lot of times, have no family history. About 5 to 10% of breast cancers can be linked to a known gene mutation inherited from one of your parents. So the BRCA gene, you know there can be mutations in the BRCA1 or BRCA2 genes. On average, a BRCA1 mutation will carry with it about a 72% lifetime risk, about 69% for BRCA2 mutation. Breast cancer that's positive for BRCA1 or 2 mutations tend to develop more in younger women. There's also an increased risk of ovarian cancer. And we know that we aren't testing as many women as we should be testing for genetic mutations. So the National Comprehensive Cancer Network gives us some guidelines, but the American Society of Breast Surgeons says we really should be testing more people and looking for these genetic mutations. We know that in the past, there were just a handful that we knew about. As the study of genetics has gotten vastly bigger, We know that there are a lot more mutations even on the BRCA genes that we didn't know existed 5, 10 years ago. BRCA2 mutations are associated with male breast cancer more commonly, less frequently in the BRCA1. About 85% of breast cancers, like I said, are in women who have no family history. So, again, most of them are not genetically linked. Things that can affect your risk, so being female and getting older, increase risk. If you have a family history, I know, it's like 2 things we can't control. Getting older and being female. Family history, genetics. If you've had breast cancer before, you're at an increased risk. Any radiation to the chest or face before the age of 30, race or ethnicity, being overweight, because we know that we store estrogen in our body fat, so maintaining a healthy body weight is a way to help reduce risk. Pregnancy history, we know in women who have no children, their risk is slightly higher. Breastfeeding, if you breastfed, your risk is slightly lower. Menstrual history, so if you started periods early and went through menopause late, that is a longer period of time versus someone who started their periods later and went through menopause earlier. So the longer you are premenopausal and the younger you started your periods, the higher the risk. But again, these are things that slightly increase risk, nothing like a genetic mutation where we're talking 70%. Lack of exercise, smoking, and then we know that alcohol intake does have some link with breast cancer, so we recommend women limit their alcohol intake, especially women who have had breast cancer. Most of this stuff I already went over, genetics. This is just what I already said. So treatment for breast cancer, it's multimodal, meaning it's not just surgery, it's not just medication, it can be any combination of things. Usually for breast cancer there is a surgical component, but there may be radiation, there may be oral medications, there may be chemotherapy, there may be targeted treatments. So that's why we have a whole team of oncologists. So you may have a surgical oncologist, you may have a medical oncologist, a radiation oncologist. So we're all oncologists, just in different specialties. So just talking about breast anatomy, when we are talking about breast anatomy, the breast is mostly made up of 2 major parts. We have fatty tissue, we have some surrounding tissue within the breast, but most of our breast tissue is made up of the lobules, which are like little tiny sacs. Those lobules are lined with a layer of cells, and those lobules produce milk. And then the ducts are like a bunch of pipes that carry the milk to the nipple. So whether you've had children or not, breastfed or not, we see that the most common places we find breast cancer are either arising from the cells that line the lobules or the cells that line the ducts. And then on this side, this is a very oversimplified drawing of the lymphatic system, but up here above the clavicle, we have the supraclavicular lymph nodes, and then these are so you can kind of see the muscle they're trying to show you here. On this view, this is the pectoralis minor, and the lymph nodes sit beside, behind, and then what we call medially to the pectoralis minor, and that's how we decide the different levels of the lymph nodes. So the ones that are beside, those are level 1. These are considered level 2, and these are considered level 3. And then the supraclavicular lymph nodes, and then there are also lymph nodes that run along the sternum. We call those the internal mammary lymph nodes. So surgical options, I'm going to go over this very quickly. But when it comes to surgical options, basically for the breast, we have two options, which is to remove the cancer and conserve the breast, or to remove the breast. When we remove just the cancer, there are different techniques and different ways to do that. When we do mastectomies, we also have different ways and different techniques to do that. Sometimes women choose to be flat. Sometimes women aren't candidates for a nipple sparing, but they're a candidate for skin sparing mastectomy, where we remove the nipple and then do some form of reconstruction with a plastic surgeon, or a nipple sparing mastectomy where we leave everything on the outside. What's important to remember is there are nerves that run through the breast. So when we remove all of the breast tissue, the sensory nerves to the skin are all divided and don't grow back. And so you lose sensation in the skin and the nipple and areolar complex if you have one, and you also lose contractility of the nipple and areolar complex. So it's rare for people to maintain that. There are some surgeries that we do to try to restore sensation, but I would say we're very good at making things look more normal, but not feel normal. Let's see. So, surgical options, again, none of this stuff is super important, but just breast conserving surgery means where we preserve the breast. Unilateral means one-sided mastectomy. Bilateral means removing both breasts. We can have a unilateral mastectomy with radiation. If you have breast cancer in both breasts, there's always a chance that you could need radiation after mastectomy on both sides. I've also had patients who opted for breast conservation on both sides and been radiated on both sides. In a simple mastectomy, we're simply leaving someone flat, so we remove most of the skin as well as all the breast tissue, and then this, if someone does a nice job, they can pull in the skin from the side, and you end up with a nice flat chest. Sometimes I'll go back for a second surgery where we have extra stuff on the side. I find that when I try to do it all at once, it kind of makes a T-junction and a watershed area, and those tend to break down. So I usually like to give patients time to heal from the initial surgery, and then I can go back and do more of a cosmetic removal of the tissue so it lays flat, because it makes it difficult when you have the, I call it the side boob, but the side cleavage, you know, because it hangs over, it makes it difficult to be fitted for a bra, and so that can be one of the difficult things. You would think that a simple mastectomy would be easier, but in some cases, it's harder to get a good cosmetic outcome. In a nipple-sparing mastectomy, the incision can be anywhere, and then we have hidden scars. So hidden scar surgery really is using kind of your landmarks so that I can do a lumpectomy through your axillary incision, do it from an inframammary incision, or usually for lumpectomies I'll use periareolar. We know in nipple-sparing mastectomies, if we can do an inframammary incision, those incisions have the best outcomes as far as tissue death, nipple and skin death. So there's some pictures coming up, so I just wanted to warn everyone. So some of the things I was going to talk about are just the changes that can happen after a lumpectomy. So this patient, this is pre-surgical, and then you can see that there's shrinkage, there's some puckering of the skin here, and this patient who has what we call ptosis, where the nipples start to face the floor and not across the room as we have larger breasts, as we get older and lose elasticity. Most likely this person had an incision on her left breast that was over here, and with radiation caused shrinkage and then pulling to the side because that tissue wasn't filled in well. So there was probably a large size lumpectomy and the patient wasn't offered a reduction or a lift of both sides at the time of surgery. So that's one of the things that I like to do for women who have larger breasts. I can do bigger lumpectomy, and insurance covers contralateral surgery. So contralateral meaning the other side, for those of you who are medical in the room. If I say words that are too doctory, just let me know so I can remind myself. Sometimes I get in the zone and forget what I'm saying. But so in this picture, we're looking at patients who had implants placed under the muscle and then had to have radiation. So we know that implants and radiation don't go well together. So you can see this is 1 month post-op, 3 months post-op, 6 months post-op, and this person had a pretty good result. Obviously this person had their radiation on the right breast and had a pretty good outcome. And down here, this patient developed a capsular contracture, which is basically fibrosis and scarring around the implant. And so I tell everyone when you get radiation, it kind of freezes that breast in time. So if you're 55, that breast is gonna be 55 forever, and your other breast is going to continue to age. And so these can sometimes be revised. Sometimes we can do a lift on the other side to help deal with the contracture. And then you can also see this patient, how high this side rides versus this side. And that can make symmetry very difficult, finding clothes that fit difficult, bras that fit difficult. So it's important to note that there is no timeline on breast reconstruction. So if you develop a contracture, or if you're 10 years out and you're starting to have drooping of one side and not the other, or you don't like the cosmetic outcomes, you can still see a reconstructive plastic surgeon and have that revised. This was a study where they did implants above the muscle, which I would say is how we do it most of the time, and then the plastic surgeon creates a hammock with a piece of what we call acellular dermal matrix, which is basically like a stratus, something where the tissue can grow in and it gets incorporated into the skin. And this is just very similar to the results that we saw before, where you can see the asymmetry from one side to the other. And you can imagine waking up, looking in the mirror, you're asymmetric. It's like when we gain weight. You don't want to leave the house, you don't want to go anywhere. It affects your entire life when you don't want to look in the mirror, when you don't like what you see. And so doing a good cancer surgery is my #1 goal, but my second goal is to make sure that you're maintaining how you look so that you can still feel good about yourself. Because I always say this, no one gets sad when they lose like your gallbladder. Like, oh, you don't have to look at it every day. But when you're looking at your breast and they make us part of being a woman, even for men who've had breast cancer, they don't want to end up with one side of the chest that's socked in and the other side that still looks like they have more fatty tissue. And so I've even had plastic surgeons do reconstruction where we did basically liposuction and fat grafting to the other side that I did the mastectomy on, so that a man can still maintain their symmetry as well. So I think it's important for men and women. So changes that happen, so this is a mastectomy, and you can see there are changes. You can see that the incisions down here and here, and what can happen is you get shrinkage. I mean, basically we're burning the tissue. So the scarring is internal, so things, and it keeps working after your radiation is over. For those of you who've had radiation and are seeing radiation changes, the radiation oncologist will be like, oh no, it'll be fine. And as a surgeon, you know, when I operate, it's like I get in there and on patients who've had radiation before, you can see the scar tissue. For people who are thinner, you'll often have scar tissue that goes down all the way to the chest wall. So you'll have pulling sensations, you can have pain where it pulls on the muscle, you can have damage to the nerves from radiation, which a lot of times causes numbness, tingling. It's not uncommon even after any breast surgery where we're cutting nerves. As those nerves are growing back together, sharp shooting electrical type sensations that kind of zap you, those get better over time, but sometimes based on where the surgery was, we are left with sensory deficits. So I think all of this I already said. So axillary anatomy, it doesn't show up very well on here, but the axillary anatomy I kind of went over already, but this is where the lymphatics come into play. So this is a little better, and these are the different levels that I was talking about. So when we know that about around 95% of the breast drains or gets filtered, so I think about the lymphatic system kind of like our body's sewer system. So in breast cancer, if we have cancer cells that have broken through a pipe, and now our sewer system is picking up those cells, what we found is that there are lymph nodes that are like gatekeepers. And if those gatekeepers are normal, then all the other lymph nodes are also normal. So what we used to do, and I think he talked about the Halsted mastectomy, which was barbaric, but even in my career, you know, we used to go in for a lot less to remove all of these lymph nodes. So level 1 and level 2 and level 3. What we found is that survival actually is unchanged if level 3 lymph nodes feel normal. So even if we have to do it, what we call an axillary dissection, where we remove all the lymph nodes, we usually leave it at level 1 and level 2 and try to maintain these level 3 lymph nodes to help with drainage. But what happens when we remove any lymph nodes, but especially with axillary dissections, where we're removing a large portion of lymph nodes, I'll talk about that in a second. There's another lymph node. So there's a fat pad. So when we go to find the lymph nodes, there's subcutaneous fat, so fat under the skin, and then there's a layer of what we call fascia that we have to provide. It's called the clavipectoral fascia. So it connects from the clavicle to the pectoralis muscle. And once you open that, then you're actually in the axillary fat pad. And I tell people looking for lymph nodes is like looking for green Easter eggs in a grassy field. So the lymph nodes are light colored and they're in this glistening fat pad, so they're not kind of sticking out easy for us to find. So when we do an axillary dissection, which I would say right now the indications for an axillary dissection are really for bulky lymph node disease. There are some newer studies that say even patients that have had positive lymph nodes, that we can get away with doing what we call a targeted axillary dissection, which is where we remove the lymph nodes that had cancer in them, any abnormal lymph nodes, as well as the sentinel nodes, which I'll explain in just a second. But in an axillary dissection, what we do is we identify the axillary vein, and then there's 2 nerves that we try very hard to avoid damaging because these are motor nerves. So the long thoracic nerve gives innervation to the The long thoracic nerve gives innervation to the serratus, and then the thoracodorsal nerve gives innervation to the latissimus. So if you injure both of those, you're going to have a shoulder girdle dysfunction. Patients won't be able to raise their arm above their head. It can cause a winged scapula. So we identify all of those things, and then we basically, without using any kind of cautery, because we don't want to injure the nerves, we remove this fat pad, and it's basically just tugging and pulling and tugging and pulling. So we're disrupting a lot of the lymphatics while we're doing this dissection. And so the risk of lymphedema is significantly higher with an axillary dissection, which is why, like what you had talked about, so there are a few patients where I knew I was gonna have to do an axillary dissection. The plastic surgeon and I did lymphovenous bypass at the same time because we know the risk is so much higher. What we do now, most of the time though, is we find those gatekeeper lymph nodes. And because somebody much smarter than me figured out, hey, if we remove the gatekeepers and those are normal, everything else should also be normal. We're able to remove less tissue and less lymphatic tissue and less disruption of the lymphatics. So it's called sentinel lymph node biopsy because we call those lymph nodes the sentinel nodes, like a gatekeeper, like your first line of defense in an army. We remove only the lymph nodes that are the gatekeepers. How do we find them? So we inject the breast with a radioactive material, so the lymph nodes are radioactive, and sometimes we also use a blue dye. And so what this does is it decreases our dissection, so we're disrupting less lymphatics, and we're removing less lymph nodes. And so then we send those lymph nodes off, and if they're normal, we assume all the other lymph nodes are normal. There's a study called the ASACOG Z11 trial where we found that actually if you have less than 3 lymph nodes positive and you're going to receive radiation, we don't have to go back for an axillary dissection. So as the number of lymph nodes goes up that are removed, the risk of lymphedema goes up. Also your surgical technique, so having a surgeon that knows their way around the axilla, because like I said, they're not always obvious. They can be deep, they can be way up under. We never know which ones are gonna be the sentinel nodes. It'd be nice if they were all level 1 lymph nodes because those are easier to get to. But sometimes they can be level 2, even level 3 for the sentinel nodes. And so the more dissection we're doing, the more disruption of the tissue we're doing. So somebody whose technique is very good, that's who you want doing your lymphatic and breast surgery. Patients who need whole breast and supraclavicular radiation. So you have positive nodes, you're almost always going to end up with whole breast radiation, tangents to the axilla, and they're also going to radiate your supraclavicular lymph nodes. And all of that increases your risk for lymphedema. And so I would say not everybody is as passionate about, not all breast surgeons are very passionate about lymphedema, but for me, I think it's one of the worst things that I can do to a patient. So monitoring for lymphedema has always been very important to me. There are a couple different methods we can use. Arm measurements, the bioimpedance spectroscopy, or the LDEX. So this uses an electrical current that's passed through the body, and basically it's the flow of the electricity through your tissue. So you don't get zapped or anything. He showed you a picture of the Sozo machine, which we use now. The old LDEX had all these little leads and wires and sticky pads, and it was very cumbersome. Now you have to take all your jewelry off, and then you have to have your hands bare feet, but the machine moves up and down, so even if you're in a wheelchair, we can accommodate patients who can't stand, and we take a reading, and that gives us an LDEX score. And the The LDEX score, what we found, is very sensitive and very specific. So the idea is that we want to get a baseline score before you have any surgery and then continue to monitor you. The tape measure, we're looking at circumference of different areas. The problem is it's not very specific and it's not very sensitive because you may not have the same person doing it each time. You may not be getting measurements in exactly the same place each time. You may not be using the same tape measure each time. And it takes a long time. The SOZO machine takes about less than a minute to do, and the tape measure takes a good bit longer. And it's just going to be less sensitive and specific. So the ImpediMed, who came up with the first LDEX and then their newer machine they call the SOZO, had a huge trial, and what they were looking for is, can we monitor patients and try to find preclinical lymphedema, meaning lymphedema before we can measure it with the tape measure, before we see anything different. And so what they did is they did a pre-treatment baseline, and then post-treatment patients were randomized into a group where they did LDEX testing and a trigger that was 6.5 change from the baseline. So everyone's baseline is going to be different. So it's all relative to where your baseline is. And then there was the volume tape measure testing and trigger, and that was a 5 to 10% change. And then we did some sort of intervention, a non-customized garment, and then we did a post-intervention testing, or they did a post-intervention testing. So they had, it's one of the largest randomized trials to look at lymphedema prevention. They had 10 centers. So the NCCN is the National Cancer Comprehensive Network. So when they have guidelines for how you treat breast surgery or breast cancer and all different kinds of cancer. And then NCI are National Cancer Institutes. Those are all across the US and Australia. And they did a 1-to-1 randomization. And what we found, I already talked about how they were randomized, and then they took measurements at 3, 6, 12, 15, 18, 21, 24, 30, 36 months with a 15 and 21-month visit with the investigator at their discretion. And a trigger was either, if you go back here, the trigger was either 6.5 change from baseline or a 10 to 15% change, or I'm sorry, 5 to 10% change from baseline was a trigger for intervention. So intervention, they use what we would call a moderate compression sleeve. So I don't know, usually they come 15 to 20, 20 to 30, 30 to 40. They use 23 to 32, and a gauntlet, so for the hand, for 4 weeks, 12 hours a day. And then they recheck them. They also, progression, so if you were progressing, then it was a customized garment and then decongestive physiotherapy. So what we saw is that there was a significantly lower progression to chronic lymphedema with early detection using the LDEX versus the tape measure. So what we're saying is the LDEX was more accurate and we could make earlier interventions, and so we helped prevent women from going into full-blown lymphedema by making an early intervention. So these measurements are important. Secondary endpoints, so while they were doing the study, they added extra items. And so there was an intensity and distress survey arm, and it's a 30-item survey, and they're self-reported. And the symptoms that they were looking for were soft tissue, neurological sensation, function, biobehavioral, resource, sexuality, and activity. They also had a functional assessment, which was a 36-item self-report looking at physical well-being, family and social well-being, emotional well-being, functional well-being, all of these things, arm-specific quality of life concerns, arm payment, that's the next one. Pain in your arm movement, trying to think and talk at the same time. Poor range of motion, numbness, stiffness. And so they were looking at other endpoints, looking at progression for patients who've had axillary lymph node dissection and some type of chemotherapy. They were looking at patients with a higher level of change in LDEX units at the time of detection from baseline that were statistically significant and correlated with higher overall symptom scores in the other areas. So when you were noted to have lymphedema in the arm, you were also noted that in these functional and distress surveys that you were more distressed and had more functional problems. So at the time, we saw patients were giving up hobbies, decreased social activity, decreased sexual activity. A lot of the decreased sexual activity is we also put you on medications that take every last bit of estrogen away from you, and I find oftentimes clinicians aren't asking the questions about sexual function, vaginal dryness, you know, if you're being intimate with your partner. I have young patients, I'm always asking, you know, are they dating? Are they getting on with their life? Because all of these things are part of treating the whole patient, right? You're not just your disease, you're a person. And so I think all of these things are very important when we're treating patients, because it is a very personal thing when it comes to our breasts. We can see them, it makes us feel feminine, and having problems with lymphedema, having problems with asymmetry, with how you feel about how you look, it causes a lot of appearance concerns. A lot of patients reported sadness, anger, lack of self-confidence, functional issues with arm movements, raising I can't tell you how many patients I see who can't raise their arms above their head. Misunderstood by their significant other. I think there needs to be more support for people's significant others as well. I think it doesn't just affect you, it affects your whole family, but especially if you have a partner, they need support and they need to know what to do to help you, as well as helping them understand what you may be going through. People felt less sexually attractive, loss of body confidence, fatigue, sleep loss. So we can predict what's going to lead to poor body image issues. We know that asymmetry happens. We know that if you have had breast surgery and you try to go and buy a bra off the shelf, it's most likely not going to fit. I can't tell you how many times I've seen patients come in and it's, you know, it's either one cup size is really small and the other size fits, or one size fits and the other side is really loose. Radiation changes can be difficult and they can be long lasting, not just the initial discoloration, but that can last. The discoloration doesn't always get better. Sometimes for people who have more pigmented skin, it can be there a lot longer. It may never completely go away. Lymphedema is a big deal. I think it's a huge deal, and I think I was in what we call our tumor board, where we discuss everybody behind their back and talk about their plan of care. And one of the oncologists was, you know, pushing for an axillary dissection, and we'll say I was pushing back, but I was a little heated. And then she said, lymphedema is not that big of a deal. And then I just lost it. So I was like, wait till you have lymphedema and then tell me it's not that big of a deal, because it is a huge deal. The loss of sensation, you know, is a big deal. And I think all of these things lead to decrease social activity, decrease in your interest in sex, the side effect of medications. Sexual activity can be extremely painful. That's why pelvic floor therapy comes in. That's where I have a list that I like text all my patients on the side so that it's not in their chart, but it's of moisturizers and lubricants and things you can try to do with your partner to help ease the symptoms, because being intimate with your partner is important, and we lose a lot of that when we are going through cancer treatment, and then the after effects. It's not, you know, when you're going through treatment, there's that next finish line. It's like, okay, I gotta get to this, and I gotta get to this, and I have to get to this. And then I call it the cliff, where you no longer have appointments all the time, and you're not seeing someone all the time. And that's when I find that patients start to feel more depressed, because you're not being checked constantly, and that's where the anxiety comes in. It does get better over time, so barriers. We know that we can predict what's going to happen, but access with insurance companies, paying for things remains our biggest issue. You know, having something like the Women's Health Boutiques and Second Silhouette is so important, and I will tell you that I've worked up in the Woodlands, and I've been in, you know, it's nice that they have a location in Willowbrook, but what they do is extremely important. And, you know, insurance doesn't cover as much of what I think it should cover, but at the Women's Health Boutique and Second Silhouette, they're very good about trying to go through your insurance and helping you through the process. I hate calling it a journey because it's not a trip anybody wants to go on. So just a little plug for myself. So I'm not doing breast surgery anymore. I'm switching into vascular medicine. So I'm going to be working, so still kind of in the lower extremity edema world, but I'll be working on venous reflux or venous hypertension. My new clinic, currently they're integrating Texas Vein and Wellness Institute into a larger company called United Vein and Vascular Center. But for right now, a little typo in there. I was gonna put the main number for United Vein and Vascular Center, but my office will be at the West University location. That won't change. Sometime in November, December, or January, the number will most likely change, but my location will not change. So about 1 in 3 people have venous hypertension, which is where our veins become dysfunctional and there's pooling, and so that can also lead to edema. A lot of patients with venous reflux also can have lymphedema. That's where the lymphedema pumps come in, compression garments, so all the things that you spoke about. So because I saw a lot of your patients were lower extremity lymphedema. So I know I ran over just a little bit. I told Deneen I would keep it quick, and I talked for too long, but does anyone have any questions for me?
Anyways, my question is, what is the difference when the implant is placed on top of the pec versus under the pec? And what would make you as the surgeon, or the plastic surgeon actually, to decide one versus the other?
So what used to be in vogue was to place them under the pec. The problem is you end up with what we call an animation deformity. So if you think about it, once you remove the breast tissue, all that's left is skin and muscle. So anytime you flex, you can see the muscle, and the implants move up and down. And so what we do now mostly is pre-pectoral. So really we're not touching the lymphatics, it's just a surgical and aesthetic outcome preference. So I would say most surgeons will put them above the pec, Some will go under the pec, but we can also do with the pre-pectoral implants, if somebody has very little body fat, they can sometimes do deep flaps and actually just use that to keep the implant and give you a little bit of tissue in between, but you don't get that, what we call the animation deformity. So it's like if you squeeze your pecs, your implants go up, and kind of like, you know, Arnold Schwarzenegger, but nobody wants their breasts to do that. And then you can also see the musculature with the implant. So I would say that subpectoral implants have just fallen out of favor in the plastic surgery reconstructive world. Oh, everybody all at once. Go ahead.
I have two-part question. Tissue expander. How long can a tissue expander be in place for a patient? And is there any damage to the lymphatics if those tissue expanders are in longer than a year?
No. So the tissue expanders can stay in forever. I think anybody who's ever had a tissue expander would say that one is one too many. They're usually uncomfortable, they ride high because their job is because after we've been tugging and pulling on the skin, we are injuring the blood vessels, or we send the vascular supply into spasm. And so if you go directly to an implant, you may overstretch the skin, and there's musculature inside the arteries. Those arteries will clamp down and all the skin will die, which is why we do tissue expanders. But I've had patients, for whatever reason, where they were delayed. So tissue expanders can stay in. You just have to remember there's a magnet in the tissue expander, so it precludes you from getting an MRI. Did that answer your question? And then there were, okay, go for it.
Can you explain axillary cording?
Yes, so what happens during cording is you're basically, so the lymph nodes are all attached to lymphatic vessels. And what happens during cording is you start to get fibrosis and inflammation along a lymphatic vessel. And so the treatment, and we don't know why some people get it and some people don't, but the treatment is usually lymphatic massage, warm compresses, and that usually will make the cording better. But if you don't realize you have cording, it's gonna limit your mobility significantly. So I also find range of motion exercises, you know, you have to start off small and then get, you know, so, but we don't know why some people get it and some people don't. It's nothing anyone did wrong, it's just we damaged the lymphatic system. So when I think about removing the lymph nodes, so if you have 100 lanes of traffic and we cut off 90 of them, things are gonna get backed up. So even if we're, let's say we're in Houston and we close one lane and then there's 6 lanes, we still are gonna have a massive backup. And so we don't know why cording happens. It happens when I've removed one lymph node. I've seen it, you know, never happen to patients. I don't know if you have anything to add about cording.
No, not really. You said it all. And it's something that is treatable, number one. I mean, it needs to be recognized that people don't have to suffer through it because it is treatable. And this is the one thing that I observe happens in slender people more often than larger people. And so for once, you know, when you have a little bit more body weight, you're a little bit more protected from cording. But I think you said it all, and I think it's treatable. We just need to recognize it.
My question is about radiation done after a mastectomy and chemotherapy. Does it affect the heart in any way? How can you not have it go as deep? Is that possible to affect the heart or not?
So it depends on which side we're on.
Left.
So, you know, the way that we used to do radiation is, and like this is well before my time, I promise I'm older than I look, but the radiation used to just be given as a single beam, and it would just be the same place over and over, and now we have it coming in at different tangents. And when they do your radiation plan, they can do things like breath holds and putting you prone, because it's outside the body. We try to minimize the tangents that are hitting the heart. And so the radiation oncologists, when they come up with their plan, they have tricks that they can do to protect the heart and lungs and ribs and other structures that are inside the chest, because we're really trying to target what's outside of the muscle. The breast is outside of the muscle. However, if your cancer was further back, closer to the chest wall, the risks are going to be a little bit higher because the tangents are going to be a little closer. As far as surgery and chemotherapy and radiation, chemotherapy and surgery can be interchangeable depending on what you have. But let's say if we know someone needs chemotherapy, they would always get chemotherapy first, then surgery, then radiation always comes last. If they have surgery first and then we find that they need chemotherapy, then we would do chemotherapy and then radiation would come last. Because radiation and surgery are for local control. That means I kind of liken surgery and radiation to, you know, a house in the middle of nowhere in some made-up Netflix land. And if it burns down, it doesn't affect the whole world. But if cancer gets into the lymphatics, that's your whole body. And so chemotherapy is always going to be more important because it affects how long you live. It affects your survival. Whereas radiation, I tell everyone, imagine you shatter a glass on the floor. If you are like anyone, this is the joke, my boyfriend's in the audience, so I hope he doesn't take offense to this. But if you're like most of the people I've dated, you get out a broom and dustpan, right? And we all know that there's still little bits of glass that inevitably you're going to step on in the middle of the night. And so radiation is a cleanup. We know we leave cancer behind. That's why the rates of in-breast recurrence are much higher without radiation. So the radiation is a cleanup, but surgery and radiation are for local control. Anything you take orally, like tamoxifen, Arimidex, or Aromacin, any of the 3 aromatase inhibitors, and some of the newer drugs, anything you take orally or take through an IV or port, that's going to affect systemically and change survival or improve survival.
Oh, well, thank you. I'm probably the oldest one here. I've been out 32 years.
Well, congratulations.
But I do have heart issues now, and I'm thinking that it might be from the way I was radiated then.
It might be.
Yeah, so thank you
Because we
very
definitely
much.
do radiation a lot differently now than we did 30 plus years ago.